I guess the first question really is, where do you see INR today? What is your feeling about it?
INR today has seriously developed to a much bigger field than it was with the pioneers in the 90s from last century. And I think the exciting thing about it that it's still growing very much. Yeah, so the development is fast. That's one of the challenges, to keep track of the development, to decide what is the right thing to use, which track to follow. But I think there's still a strong growth. Stroke has been one of the big motors to make it bigger and create interest from the medical industry to provide products, because the market is bigger, so there's more development. And I think INR has become one of the fastest developing specialties in medicine in our time.
When you were saying the mechanical thrombectomy is something that's established now as a standard process, and as you deal with aneurysms and AVMs and other things, you were talking earlier before about remodeling, and do you have all the tools you need to do the various interventions, but outside of the initial mechanical thrombectomy?
Well, I think we have a bunch of tools which is much better than what we had in the past. So we're in some way, compared to the early thrombectomy and neurointervention, we have developed, and now we're almost spoiled. So if somebody starts new, the material makes it so much easier. So kind of tailored instruments for special purposes. Yeah, so it's just the biggest difficulty is to decide which one today for this case, and so to train neurointerventionalists to select the right product, to have a kind of like a base platform where you can escalate according to the individual needs of one intervention.
And is that just within your own hospital, or is this something that's universally accepted?
I think that's universally accepted, yeah. So I think it's one thing is to transport the different skills. I think when you look at that, how I was trained, or the interventionists before myself were trained or had to train themselves practically, is that the simple material is much more difficult to deal with, to make it follow your needs. And but this gives you a serious, deep understanding about the mechanics and where the problems are, what is the biggest challenge to come over, where are the biggest dangers. This is creating a certain skill level, which we have to translate with the new products, which make it much easier. Yeah. So I think where we need much more to make the best use of the big portfolio we have now is a modified training for that, and I think simulation is super important with that, because you can compare it with car driving, yeah. So if you're in the 60s, 70s and have a 911 Porsche or another sports car, yeah, you needed a different skill level than in our days, where you have all these assist systems with driving. Robotics has been a big theme here also already, with impressive life cases from Vitor Pereira from Toronto. And I think if you integrate it in the best way, then you can bypass that lack of experience when you start from as a pioneer and learn where are the difficulties. To teach one of the young drivers for sports cars today to drive one of the old cars is more difficult than adapting to the new technologies, accepting special assist systems, yeah. And I think we could see it very well in Vitor's live demonstration, how he was using the robot, kind of like with reducing the speed and movement array of the robot to be more precise, slower, getting So that's
and it was interesting because he said that he didn't feel like he had less control.
Yes.
And there was that comment made, I don't know if it was by you, that it was training a fellow might be the best training for robotics because you have to stand back.
Yeah, I completely can sign that statement. Yeah, so it's when you start training a fellow, yeah, so you know how it feels, and so you have to change your mindset a little bit if you want to still help him do it himself. Yeah, so if you're impatient and want to touch it, then it becomes difficult to train him. Yeah, so you focus more what you see with your eyes, and if you understand what the wire is doing, so meeting resistance, buckling a little bit, so all these tiny signs you see there, you can translate into what you're used to get from your haptic experience. And the same thing is happening when we each other help each other with proctoring. Yeah, so experienced guy knows one product, teaches another experienced guy. So you're not allowed to touch anything. So you need to translate that.
He said another thing was that you don't realize how much you depend on imaging and not on touch. And that's actually probably something that's developed in the last 10 years with the improvement of imaging.
Yeah, the imaging, kind of like, don't know what you're referring most to, the angiographic imaging or all the diagnostic
Well, he just simply
before?
said that one of the questions about losing that field when he's behind the machine was that, in fact, there's so much of your time is spent looking at all the imaging.
Yeah, that's right. So you get the overview, and it's, I think, it's the essence what you collect from the different images, the different planes, but also the image quality. So to see a tiny stress in a microwire, you need a very good image quality, which wasn't available in the same quality 10 years ago.
Let's just turn briefly. You just did a first in man of a new product. You want to speak a little of that?
Yes, thank you. That was so technically spoken, it was not a real revolution. This has been done many times before, but it's first time that classic remodeling stent used for treating aneurysms, open cell stent, the PEGASUS, is available with thrombogenity reducing coating. There's HPC coating what this stent offers. This technique this coating has only been available yet for flow diverting stents. So that's the most expensive product, which is most on vogue and meeting several indications. But if there's a big advantage for thrombogenity reducing surfaces, then there's no reason to restrict that from other implants we're using. And I had the honor to present this case, which was a difficult indication because the patient was also pre-medicated with anticoagulant rivaroxaban, 10A inhibitor. And if you give dual antiplatelet, then it's like a triple anti-thrombotic therapy, and we know all that goes together with the increased bleeding risk. So the presentation was then about to implant this new, also antithrombotic coated stent in a setting and demonstrate that with this indication, and you could safely do that like you used actually also from previous products which didn't have the coating. So mechanically it was just this, no challenge for me, but it's also important to improve that this new product behaves the same way, so that you don't need a new learning curve, or so you can use this product like any other you're used to.
With the goal of reducing the danger of dual antiplatelet therapy.
Exactly. That patient I put on single antiplatelet medication while continuing her anticoagulative treatment with rivaroxaban, and so giving her in combination with these implants still a sufficient protection against thromboembolic complications or a stent occlusion.
This could be critical in patient selection. This could be critical in future.
Yes, so that's very important for patient selection with concomitant diseases, which is a big topic we all get older than we used to, so the amount of concomitant diseases together with an aneurysm is rising. So the likelihood that we meet patients with the extra need for other medications which are in concurrence to what we need to do and give more conflicts. For example, there's also surgical needs, so not everybody can get the aneurysm treatment and then wait 3 or 6 months until you can cease the dual antiplatelet medication, because there's also maybe cancer or dentist or so. So that makes life easier. And with these coatings, it might be, depending on the outcome of future studies, that we might end up that we have to temper with the very complex thrombus formation and thrombus resolution system of the body less long, just focused in the short time period around the treatment, less aggressive. Yeah,
Yes.
so that would be the best outcome of it, to my opinion.
Well, thank you. Do you have any other last comments you want to make?
I love to be here at LINNC. It's a great experience, especially as due to this live transmission from different parts, North America, China, but also Paris. You get experienced teams from different parts of the world, and you know, they all have a different upbringing, a different school, yeah, and you learn a lot by listening to different experienced people from different parts of the world, because they're all know how to do things, and you can learn everything from a different point of view, and that's very valuable for me. And so I always like to look at other kitchens.
Very good. Well, thank you for being in our kitchen today.
Yeah.
And we look forward to seeing you next year.
Yeah, thank you so much. The pleasure was on my side.